started, we had only not more than 100 pediatric endocrinologists in the country, and the burden was huge. So there were thousands of cases of pediatric endocrinology were there, but then there were very few to cater them. So what we thought that there was a need somehow to have bridge in between them to develop special interest in pediatricians and physicians, and then they can really match and manage the overall case. Since then, there have been definite improvements which have happened, and now so many new things have happened. But this was what when I started in 2007 in that regards. So we started off and we realized that awareness was a major problem. So whenever we talk of a disorder, we know that there are three things: awareness, accessibility, and affordability. Now, everybody says it's affordability, especially when it comes to hormones. They're expensive, were difficult to get, but it's actually awareness. So we started with pediatricians' awareness. This was in 2012, and we can see many of the people who are still there. Many of the faculty is the same from that time. It's continuing from there. And then we conducted a number of programs across the country. We developed 6 modules, which are still the base of many of our courses. Till now, we have conducted 120 workshops, 15 practical pediatric endocrine courses across the country, and 5 advanced pediatric endocrine symposium. This is the 6th one that we conducted. So this was the first one in 2017, and we can see Dr. Hemchand here. So he was there right away at that point of time. Again, Dr. Hemchand talked about bone age. We discussed about this. Then there was a couple of year gap because of COVID. Since then, we have been having annual events every year. Every time we have got very good people coming from across the country. Now, after conducting so many programs, what we realize that once you conduct the program, people forget about that. Whatever you teach, they will just don't remember. And it is too much effort to go in terms of money, in terms of time, manpower, and everything. So we thought of using the power of social media to highlight that, and we set up this channel, which is now one of the largest channels as far as pediatric endocrinology is concerned. And it has been viewed across the globe. It provides, there are over 400 videos and everything on pediatric endocrinology. So anything and everything, it's available there. We then thought of in terms of systematic approach in terms of pediatric endocrinology learning. So we started off with our fellowship program in 2017. And as Dr. Ravindra was saying, that we are now recognized by the National Board of Examination. And it was in fact a dream for the last 10, 15 years that we were pushing for pediatric endocrinology fellowships, which were not available from NB. And now finally the dream has come, and BJ Vadia and our center is now the 2 centers which are going to provide training in pediatric endocrinology. Now, what we realize that even physical fellowships, many people who have done training and who are in practice or doing some medical education, they are unable to really come in for 2 years because it's very difficult for them to join and leave the practice. So we started with online learning in terms of medi classes followed by books. And then we thought if you want to empower people to develop applications so that they can use, and we discussed some of the innovations just recently. Our fellowship started in 2017, and both of them are here. Dr. Neha and Dr. Chetan, they started with the first program. Dr. Riddhi and Dr. Sajali was also there in the second group. Dr. Pratik is currently in UK. Dr. Sayan and Dr. Naveen are now pursuing DM courses in PGI Chandigarh and at AIMS Delhi. Dr. Manoj was here. As we can see, Dr. Vibha has joined with us as a consultant. Dhwani is currently in Patna, so we have people across the country. And we have got Dr. Alapan and Sandeep who are still there, who are working. And Dr. Nimisha is the last one to join. So we've got 13 people who have joined, and hopefully very soon we will have the National Board Accredited Fellowship, which will start here. Our learning portal provides validated tools for evaluation, assessment, and pediatric endocrinology, including a full fellowship in pediatric endocrinology. So we launched around 3 years ago, fellowship program in pediatric endocrinology, which was a very, I would say, a tough program. It has 2-year learning. Every 2 months, there are online exams. There are continuously lectures every week. Every 6 months, there is a 5 days program in which they come, they see a lot of patients, we discuss with them, and then this program happens. So there are 4 sessions which are there. We have developed a mobile application, which in fact is the most downloaded endocrinology app, and we talked about publications there. We are developing other tools like personalized intelligent EMR, which will help guide evaluation and management of pediatric endocrine disorders. We have developed BIG, the bone age assisted interpretation of growth, which recently Dr. Vibha was just talking about how it will help assess puberty, growth, bone age, and obesity at one single click. You will be able to get all the results. We are developing a personalized expert for nutrition in which it will analyze all your meal items in terms of lot of input which we don't know about glycemic load, all the other aspects, and then it will also provide based upon the requirement the recommended 7-day allowance. So automatic diet chart will come in for patients, which is coming up. We have already developed the Diabuddy app, which provides insulin dose guidance based upon glucose as well as carbohydrate counting, which is there inbuilt in the app. And this is being validated right away. So hopefully next time we would be launching it in a proper for a general use in that perspective. We have got number of books, basic, pediatric, and advanced. So we have tried to do a lot in this area over the last decade or so. Many of our efforts have been recognized. As I showed, Dr. Riddhi won the award for Best Bone Age Presentation at Kolkata, Dr. Sayan for Puberty Interpreter, Dr. Alapan at APES, Dr. Dhwani won the Kaichi Kida Award for the DSD Interpreter, Bone Age Assisted Interpretation for Growth, Dr. Vibha. Then also, so all of presentations have been there. There are a number of publications coming out of our tools, which have been validated and developed. So our fellowship in pediatric endocrinology, as I said, is a comprehensive one. There are over 100 modules, approximately 1,000 hours of videos that people have to watch. Pre-test, post-test, live lectures are there. There are on-site 4 visits with hands-on exposure. Assessments are done bi-monthly, 6-monthly, and an exit exam. And then there are other opportunities to collaborate in terms of research, learning, and teaching. So we have had multiple, we had now 9 on-site courses. This happens every 6 months. Started from 2019. To date, we have had all these on-site courses, and we can see many of the places which are here also. So this was the last course which was done just in June 25. And all of them, I think most of them are here. And this was the extensive program in which we had 300 patients coming from growth, puberty, thyroid, electrolyte, all the disorders. And they were discussed in intensive fashion. And discussion was there. So till now, 48 people have been awarded fellowships in this program. Ongoing 72 people are doing fellowship. There are many other courses also where people are enrolled. That number goes to thousands or something. 12 nationalities have been enrolled on that. So this is a way in which we are trying to increase the number of people who are working towards pediatric endocrinology. Focusing on genetic glucose disorders, a word about monogenic diabetes before we go ahead. So type 1 diabetes, we know 80% of cases is type 1 in children. Type 2 is around 15%, in MODY will be like 2 to 5%. So we need to know when should we suspect monogenic diabetes in that regard. So it's 0.4% of all diabetes. But if you identify monogenic diabetes, you may be actually able to provide a specific treatment. You may give oral medications. Some may respond to sulfonylurea, some may respond to GLP-1 receptor analog. And you know whether there is a kidney association, liver association, which is there. So we all know that if you have a child who is onset between 1 to 10 years of age, it's usually type 1 diabetes. Default mode is type 1 diabetes. If you have a child who is obese or overweight in 10 to 18 years, pubertal, think of type 2. Lean individuals with multiple generations involved, you should start thinking of monogenic forms of diabetes. So clearly, if you think of monogenic diabetes, typically they present at 10 to 25 years of age. Almost all of them are pubertal. This is an autosomal dominant condition. Ketosis may be there in 5% cases, and C-peptide will be normal. So these clues will give you the clue. So in child who looks like type 1 diabetes, but who is not requiring insulin after 1 to 1.5 years of age, has a strong family history of diabetes, has negative antibody, we should start thinking of genetics from that perspective. Similarly, suspected type 2 diabetes without obesity. So this is our algorithm. So what we say is that onset before 6 months, Dr. Neha very clearly said that you should get a genetic testing done. After 6 months, depending upon the insulin requirement and the phenotype, we can decide. So lean individual not requiring insulin for more than 1 year, we suggested you should do a monogenic evaluation from that perspective. So monogenic diabetes can be because of insulin deficiency on one hand, in which you have a problem in transcription factors. And on the other hand, you will have a release defect. The classical example is glucokinase. The characteristic feature of transcription factor MODY is high fasting, high PP. While if you talk about glucokinase, it will basically have fasting is high, but the delta increment is quite limited in that perspective. Then there can be resistance syndromes as well. So we'll start off with the cases, Dr. Nimisha.
Starting with the case one, 15-day-old girl presented with failure to thrive. Birth weight was 1.8 kgs. On presentation, the weight was 1.6 kg. The baby was looking sick. The blood glucose levels were high, 425 milligram per deciliter. The ketones level were low, and the child appeared dehydrated. To Dr. Vijaya, sir.
Yeah, working. Okay.
And her weight is 1600 gram, and she is sick looking. So first, and there is high blood sugar, blood glucose levels are 425, dehydrated. So first of all, you have to think, because we are dealing with a premature child, and we have to discuss and we have to investigate about sepsis and other conditions, at least especially fungal sepsis, and can produce hyperglycemia. That may be the first thing. And along with that, we have to, as discussed in the previous topic, we have to discuss we have to we have to think that this child is having neonatal diabetes also. And since the child is below 6 months, always genetic study is a must in this case.
Yes, sir. The child was started on fluid and insulin, and the genetic study was planned.
And the other thing that there were no other infection markers. And
Yeah.
this was a persistent diabetes. Now, the problem with this patient often happens not affording genetic study.
That a very
So what will you do, Dr. Vijay, here?
So if the child is not affording genetic study, I think we have to start insulin. And the problem is that many a case, this genetic cases may require sulfonylurea. Here also we also have some problems to, so some delay in the diagnosis. So we have to start insulin. And this child improved our time with insulin.
Yes. And then the requirement. So everybody happy.
Then
We were happy. Patient was happy that there's no need. But do you think we should be very happy now, or we should be cautious?
We have to, even though the child improves, and we have to follow up the child. So
Dr.
because
yeah,
they can develop later, during adolescent period and somewhere like that, they can produce diabetes later, monogenic diabetes.
So Dr. Ravindra, in this, the questions, Dr. Ravindra. So as we were discussing, this looks like a transient diabetes, but what are the issues that we should be following up in this child?
So as you have very rightly in neonatal diabetes, we have already discussed that this case is supposed to be neonatal diabetes. Improved means must be having some transient form. And there are chances that this transient form may recur. So just keep under observation. Otherwise, this patient will end up in decay someday. So always keep monitoring this patient. And if it develops, if genetic study possible, then it's okay, very good enough. Nowadays, as Sir Dr. Anurag said, I mean, it is a costly therapy. Okay, yes, that is fine. But neonatal diabetes is one arena where free diagnostic is available. In India, Dr. Madras from Chennai, he's doing, I mean, you can send him sample and he'll do it free of cost, hardly costing 250 rupees.
Yeah. So now at 12 years, Nimisha, what happened?
On following up after 12 years, child presented to us with polyuria with high blood sugars, 240 milligram per deciliter. The HbA1c level were high, 8.4 percentage, and child was started on insulin again. The plan of management.
So as Dr. Ravind, you said that genetics should have been done right away. And that time it was quite like 15, 16 years ago.
Okay.
Now the genetics was available. And what do you think would be the most likely type of diabetes in this case?
I mean, this must be some 6q24, as we have already discussed. Transient neonatal diabetes is supposed to be 6q24, which is having a biophasic curve. During the adolescent time, at 12 years, it again resurfaces. Now, patient is having the diabetes, any type of diabetes, the management will remain the same. It has to be basal bolus regime, start on insulin, and it will continue on insulin because mutation is there, which has given its own effect now.
Yeah. So now we got the genetics this time and we found the ABCC8 defect.
ABCC.
So this is the potassium ATP defect. So now we have a theoretical option for switching over to an agent.
Switching, because now this is the one arena where you got this ABCC8, because just ABCC8 or KCNJ11, both of them, they respond very well to the sulfonylurea. So there is a schematic diagram, because first treatment has to be the insulin, whatever may be the type of diabetes. Always, because our first aim is to control the sugar. After that, with that systemic schematic diagram or program, we may shift it to the sulfonylurea. Probably it will respond to the sulfonylurea now.
So, Dr. Nimisha, what happened with sulfonylurea in this child?
The child was started on sulfonylurea, and
He
on follow-up, child insulin was decreased gradually, and child blood sugar levels came to be normal.
This child just came to our on-site course recently. Now he's only on glibenclamide, 10 milligrams,
Right.
a perfect HbA1c. So, Dr. Ravindra, what are your messages for neonatal diabetes?
So neonatal diabetes, as we all know, neonatal hyperglycemia, although whosoever is looking after nursery, is an uncommon thing, because neonatal hypoglycemia is very common. In every case you will be having neonatal hypoglycemia. But any neonate who is less than 6 months of age having hyperglycemia for 2 weeks or more than 2 weeks and require insulin for the treatment probably qualifies for neonatal diabetes. You have to treat that patient with the insulin irrespective of the etiology. Keep monitoring the patient even if the genetic study is not possible. Any mutation of a ABCC8, that is why it improved over the time. Otherwise, it would have resulted into the permanent neonatal diabetes.
Thanks a lot. Yeah.
Moving to the second case, 2-month-old boy presented with failure to thrive. Birth weight was 2.5 kg. Now the weight was 2.8 kg. There was hepatomegaly, myopathy, and weakness at the time of presentation. Blood sugar levels were high. HbA1c was 9.9, and triglyceride was 550 milligram per deciliters. I would like Dr. Hari sir to kindly comment on this.
So, looking at the child profile, an RBS of 487 with high HbA1c suggests a possibility of diabetes, and looking at the age of 2 months, it is neonatal diabetes. Okay. Now, whenever we encounter such patient, we have to start on therapy with insulin and send genetics. This is the first plan we should have, because unless we have a diagnosis, genetic diagnosis, we won't be able to plan whether the child can be shifted onto sulfonylureas.
And if we compare to the last case, Dr.
Yes.
Hari, we have some subtle clinical pointers which are
Yes.
different in this case.
So here, myopathy, weakness, hepatomegaly. These are the additional findings apart from this. So this suggests some kind of specific genetic mutation. Now, what are the genetic mutation? The potassium channel defect, which is common in muscle and neuronal tissues, that if there is a severe KCNJ affection, the potassium channel affection is there, then it may actually affect those neuronal tissues and muscle, causing myopathy and developmental delay or epilepsy kind of a syndrome. So if we actually think of some syndrome, the KCNJ11 including that, Dent syndrome is one of the syndrome which comes to the mind, which is developmental delay, epilepsy, and neonatal diabetes. So yes, if we do this targeted panel, KCNJ defect was seen in this child. I may not go into details of the cell physiology as it was adequately discussed in previous talks. But a KCNJ defect, if they are in intermediate variety, then we may actually not have epilepsy, only neonatal diabetes, and some developmental delay can be seen. So this is present in almost say nearly 15 to 20% of total cases of KCNJ, a severe variety.
So what will be,
What will be the plan of
So
management?
plan will be starting them on once they have started on insulin, gradually shift them on sulfonylurea drug, because they are known to respond to sulfonylurea. And KCNJ, they respond, most of them they respond to sulfonylurea.
So all newborns in the 6 months of age, 6 to 12 months, antibody negative with diabetes should have genetic analysis, and later onset, as in this case, can also be indicative of a permanent one. Genetic testing becomes well in that regards.
Actually, I have shifted one of my patient to sulfonylurea, neonatal diabetes. They could not do genetics. So, but the transition was successful. So I think most of them they we will be able to successfully transfer them or shift them to sulfonylureas. But genetics done will be able to give them a future perspective.
So that has to
What
be very cautious because only 40% will actually respond to sulfonylurea. We agree that you were there, you were monitoring very closely.
Yes.
So we should not give a advice that you do that because otherwise they will go into decay also. But
No.
yes, under a very close monitoring, we can consider that as a trial. But ideally, genetics, as Dr. Ravin said now, MDRF does it for free. So only courier charges have to be given. So that can be considered here. Okay,
Coming
next
to
case.
case 3, a 12-month-old girl, failure to thrive with birth weight of 2,500 grams. Blood sugar levels were high. Ketone was not detectable, 0.3 millimole per liter. There was a history of consanguinity in family, and a X-ray film of hand was done. Dr. Chetan, sir.
So again, this is a case of diabetes which presented at 12 month. So this can be type 1 versus monogenic. Uh, this is non-ketotic diabetes, so it may be detected early whether ketosis has not developed yet. But looking to the X-ray, we found bullet-shaped fingers, which is not normal and which is unusual. Also, there is history of failure to thrive and family history of consanguinity, which is suggestive of monogenic possible genetic cause of this diabetes. And we know that the skeletal dysplasia along with the type 1 along with the neonatal diabetes favors EIF2AK mutation, and the name is Walcott-Rellison syndrome. So we should be again looking for the genetic diagnosis whenever there is diabetes with specific other symptoms and signs suggestive of monogenic etiology.
So again, this is one condition which is having beta cell destruction, and ultimately they will be insulin dependent only. So as I said, only 30 to 40% will actually be sulfonylurea responsive. So clearly it is the commonest cause in consanguineous family. And if you have skeletal abnormalities, always look at fingers. You will find this as a possibility. Have you experienced hepatic dysfunction in this condition?
No, I have only one patient of confirmed genetic mutation of EIF2FK, in which the patient is not responding to the conventional dose of insulin. Currently, he is on 2.53 unit per kg per day, still having sugars in the range of 250 300s. Also, there is a component of failure to thrive. In that patient, SGPT is remaining between 40 to 80. So there is not much hepatic dysfunction, but overall the patient is having trouble in terms of digestion and persistent vomiting is there. It is not growing well. So I have explained them poor prognosis, but again, this is fairly common.
Yeah, so Western reports say universal, but there are many Indian patients who have not developed. So probably we have a different mutation which is there.
Moving on to the next case, 2-month-old boy presented with failure to thrive with high blood sugar levels, with skin infections, diarrhea, and on checking the GAD antibody, it was positive. Dr. Vijay.
So is it type 1, Dr. Vijay?
So the GAD antibody is positive, but here the main problem is child is having diarrhea and child is having skin infections. So it is an autoimmune process, but we have to investigate for other causes also. So many cases, so this is almost a clear-cut case, IPEX syndrome, but we have to investigate and find out. So sometimes many immune defects can be a part of type 1 diabetes, as we were discussing little bit earlier, immune endocrinopathy. So lot of things are there. It was a very nice talk, and we have to investigate for other immune systems also.
So Dr. Neha just mentioned that antibodies may be positive in younger children. That does not mean it is type 1. It could be IPEX also. So this is a bad condition. IPEX generally is a very, very bad condition. It causes a lot of other problems, abdominal symptoms, pancreatic, thyroid, immune. Do you have any experience of this condition, Dr. Vijay? Not really. But this is, I have had couple of cases very bad outcome. Even in Western countries, it is a bad prognosis. Only treatment is hematopoietic stem cell transplant, which is considered in this scenario. So this is a bad scenario. So if it is early onset immune diabetes, multi-system, think of IPEX syndrome. Now, next case, please.
16-year-old girl presented to us with increased urine output with high blood sugar levels, HbA1c of 8%, Ketone was 0.8. BMI was 16 kg per meter square. There was no acanthosis and diagnosed as type 1 diabetes mellitus. On insulin, there were repeated episodes of hypoglycemia. Dr. Ravindra, sir?
So that's very interesting case that at the age of 16-year-old, she was diagnosed as a case of diabetes as with RBS and non-ketotic, but patient is not in DK. Obviously, patient is not obese, so BMI is just 16. Now, interesting is that when it is a case of type 1 diabetes mellitus, and she has been put on the regular management as a standard protocol, why the patient is developing recurrent hypoglycemia. It means, I mean, this can't be some type 1 diabetes. Had it been type 1 diabetes, and if we are treating appropriately with the right dose of the basal bolus regime, it means it is something which is in between. And when someone is adolescent, you know that there may be something more than that because we have not done the antibody in that case. And if we see the algorithm, because now, as doctor, she has projected that she has gone the antibodies and it is negative. Now, here comes the role of you will think, can it be a MODI? Because this is the case where the scenario patient may develop hypoglycemia based on the insulin, and you have to be very careful. Just take the history. If this is the third generation, see, so one of the parent is having diabetes or their brother and sister and their grandparents. Third generation, always look for the MODI, do the genetic testing again in that case, because this might be one case where that patient may need only tablets and oral medication may be done. So if we go to the algorithm, as sir has already shown, that it is 16 years, get antibody positive, there is no obesity, negative or positive genetic study, then genetic study has been done and it is came out to be HNF1 alpha defect, means again it's a MODI which may be treated with the and all these late onset progressive fasting normal, as sir has said, and that may be management by just OHA, oral hypoglycemic acid, then they will respond very beautifully.
And very good thing is that the GLP-1 receptor analogs are very, very
Very,
effective without even causing hypoglycemia. So if you diagnose them, you start 0.5 milligram of glimepiride, they will do wonders. So this is one condition of insulin. So this is a very good drug disease to have. So as Dr. Ravindra said, that lean, low insulin requirement, 3-generation family, get a targeted panel. Don't rush in everybody. So what we say, if your insulin requirement is persistently low after 1 to 1.5 years of diabetes,
Yes,
that is
that is
the
low.
clear-cut scenario. Otherwise, genetics, a lot of people keep on doing genetics a lot. That should be avoided.
That is a very, I mean, message is very loud and very clear. You know, there is a honeymoon phase, and this, if honeymoon phase is persisting, because usually persists for a couple of weeks. If persisting more than a year, then this is not a type 1 diabetes. You have to look for probably you are dealing some sort of MODI.
Coming to the next case, 15-year-old girl presented with osmotic symptoms. Fasting was high, 220 milligram per deciliter, and 2 hours OGTT level was 380. HbA1c was 10.4. They were started on insulin. Child was lean, no acanthosis. There was family history of similar complaints in mother. Fluctuating sugars after and insulin was stopped. Dr. Hari sir?
Yeah, so fasting sugar high qualifies her to be a diabetic person with two criteria met. Though she had DK and recovered by insulin, she's lean and no acanthosis, so there is no type 2 diabetes. There is a family history in the mother, and the sugars are fluctuating. And she was, I think I read somewhere. So again, this becomes a case going towards MODI because there is a strong family history, and she's requiring low doses of insulin at that time.
So this is
So
persistently low
again,
insulin
persistently
requirement.
low insulin requirement. And yes, now this is a renal ultrasound, which is like showing some cyst in the kidney.
Yeah.
So HNF1 beta again is known to have extra pancreatic manifestations. In fact, it can be the renal cyst which appears first, and patient may present with renal cyst without diabetes. Later on, they may go on to develop. And hypoplasia of other organs, particularly they have pancreatic hypoplasia and reduced secretion of exocrine pancreatic insufficiency also. The thing which we see in such patients is they respond to sulfonylureas, but the response is not a long-lasting response, and most of them they will be have to shift it to insulin therapy as the disease progresses. So it's a late onset kind of a progressive disorder, renal cyst dysplasia and pelvic
So
defect.
this patient also had to be started on insulin after glibenclamide. So again, fluctuating course, renal cyst, family history, think of HNF1 beta defect.
11-year-old girl, type 1 diabetes, diagnosed at 8 years of age, started on insulin at 1 unit per kg per day, presented with visual complaints of and was diagnosed of retinopathy. Dr. Chetan, sir.
So this girl having a duration of 3 years of type 1 diabetes, insulin requirement is stable at 1 unit per kg per day. So very unlikely that this patient will develop type 1 diabetic complications as retinopathy, because we generally observe that retinopathy and nephropathy usually starts occurring after 10 to 12 years of type 1 diabetes. So this might be another genetic thing which can lead to type 1 diabetes along with the visual effect in form of retinopathy. So maybe again genetic evaluation is warranted, and we have Didmode syndrome in which the patient develops type 1 diabetes insipidus as well as hearing defect as well as retinal issues in form of optic atrophy. So this is a Wolfram syndrome rather than plain type 1 diabetes.
This is very important to identify because the prognosis is very bad for this condition. So general guidelines are that if you are antibody negative, an early onset visual complaint is equal to Wolfram syndrome. That is something which is very, very clear in that regard. So this case turned out to be a Wolfram syndrome with a bad prognosis. So non-immune diabetes, early onset optic atrophy is Wolfram syndrome. Again, genetics is very, very important. Remember, we always say did mode, but DI happens much later. So don't think about DI is not there, so why it is did mode.
Coming on to the next case, 11-year-old girl, on routine investigation, the fasting blood glucose levels were found to be impaired and the postprandial blood glucose levels were normal. The BMI was 18 kg per meter square. There was no acanthosis. HbA1c levels were high, 6.4, and ketone was low. And started on insulin but developed hypoglycemia. Dr. Vijaya, sir.
Here it was antibody test was done or not done. GAD
Yeah, we got the test done later on.
negative.
Yeah, but we
So this is a almost clear-cut case of GCK mode because all these things are there. So postprandial is not much, and whenever you give insulin, child will develop hypoglycemia. That is a very benign disease also. So you can, without insulin, we can manage the child.
Yes, sir. The GAD antibody was negative and child had a high fasting glucose with postprandial
postprandial
increase was
minimal.
minimal. This was a glucokinase defect.
Glucokinase deficiency.
So glucokinase deficiency, as you said, there's a problem in glucose sensing. You have high fasting, but the sugars immediately get in control. So this is something the delta value is usually less than how much, Dr. Nimesha? Less than 40, maximum 50. So from fasting to PP, the rise is less. They do not need treatment. The only condition where they may need treatment is pregnancy. When the child is not affected, then they will behave like IDM. So lifestyle measures are required. So this again is a mild diabetes, non-progressive, no need of treatment. So we have seen so many children with diabetes who require either oral or who require no treatment at all. So it's not that every childhood diabetes will require insulin. That is also something we are giving a message.
Moving on to the next case, 12-year-old boy presented with polyuria, developmental delay, history of hyperphagia, infantile hypotonia present with fasting blood sugar levels of 140 and 2-hour blood sugar levels were also high. The child was obese. Dr. Ravindra, sir.
Actually, I want delegate to answer it. I mean, you can't have more apparent clinical diagnosis. Yes, but the case is Prader-Willi. So you see, all of you have become so intelligent after the whole days these lectures. So everything this patient is having, diagnosis is written on his forehead, although it has been blacked out. It is a case of Prader-Willi syndrome. It is difficult to manage because there are so many problems are there. Diabetes is just one part of them. Hyperphagia, hypogonadism, many things are there. So this is Prader-Willi syndrome. You know that. If possible, genetic testing may be done. Treatment is very difficult, although metformin and now we have GLP-1 analog. And recently, I think whosoever is member of endocrine group, one drug has been approved for this hyperphagia, because hyperphagia is very problematic. I don't know how many of you have seen this sort of cases. I've seen two cases, and believe me, I mean, they are very difficult to treat, number one. And number two, this is not that rare as we think of. The incidence is just close 1 into 25 to 50,000. So if you look at the daily 2-3 crore population, so how many PWS are moving here and there? However, infantile hypotonia, later obesity, hyperphagia, diabetes in second decade, we have to be very careful, especially who are doing in nursery, because the neonatal hypotonia, earlier very low birth weight, and then suddenly they start from 6, 7 or 8 months, they start gaining the weight.
The main message is if they develop diabetes, you're too late, and by that time it is going to be very difficult. In the Western countries, the average age of diagnosis of Prader-Willi is in the 6-month age. So they're picking up neonatal, so they do all that to prevent obesity. I have found very much difficulty. This child had sleep apnea, he was on ventilator, CPAP, insulin, so it's going to be a real mess. It's not an easy one. Maybe think of bariatric surgery, GLP. It's like a desperate measure, but we should work early. I have given growth hormone to a few patients who have done well because they have not gained weight, but they have become diabetic. I think this is pretty much a very, very bad scenario in that regards.
Next case, 17-year-old girl presented with hirsutism with Perriman-Galway score of 21 and complaints of amenorrhea. There was severe acanthosis. The BMI was 16 kg per meter square with blood sugar fasting level was 145 and postprandial was 221. USG shows large ovary with PCOS appearance. Dr. Hari sir.
So when we look at the complaints, they are very clear cut, suggesting of PCO, the diagnosis of polycystic ovary and acanthosis. This all point towards insulin resistance, and the major cause of insulin resistance is obesity. But here the BMI is less. So there is insulin resistance, no doubt about it. But the cause is somewhere else. The cause is not the obesity. The cause must be in the INS or insulin receptor gene. So
Yeah.
if
This
we
case
see this,
basically we are treating as a, we did not get the genetic
Yeah.
study done. We are assuming this is more like a autoimmune insulin resistance which
so
happens
yes,
later on in life.
and it's like many different types of presentation. One is heterozygous, which is the mildest form, and then we have homozygous form, the so-called Donnai syndrome, and a compound heterozygote also, which is Rapson-Mendenhall. So if there is absolute resistance to insulin, then it is very severe neonatal onset condition, very difficult to save such kids. The easier ones are this infantile onset insulin resistance, and type 1 is the mildest form, which can be managed by metformin initially, and perhaps
But often they are not very mild, because this case, what happens is that ovary was very big and it had led to testosterone levels of 200 and above, causing virilization. We saw this case in the on-site course, and we had to actually do a ovarian drilling to remove part of the ovary. And very, very difficult, because otherwise they will go into severe this is like hypertrichosis. Heron syndrome is what we typically say. This
So
is very,
what,
very
like,
bad scenario.
what I want to mean is, amongst the
Yes,
insulin resistant type, this is the mildest
True,
form.
absolutely.
But otherwise, clinically considering PCO, this is the most severe form. And I mean, testosterone of 200, we can just imagine how the child must have.
So this is very, very dangerous. Again, if we wait for some time, the ovaries will be burned and then ovaries will behave like a bomb sort of a thing. They're producing testosterone like anything. In one child, we had to give GnRH analog to knock down that. We had to give anti-androgen. We had to give estrogen to increase SHBG. So it's like a nightmare. So this case, we earlier got a ovarian drilling done. So now she is relatively better. But again, hirsutism is persisting, I think. Yeah. So now we have talked a lot about monogenic diabetes, a bit about hyperinsulinism. My work has been done, made very easy by Dr. Vijay Kumar, who has talked very clearly. So very situation in which you have a hypoketotic, non-reducing substances with detectable insulin is hyperinsulinism. This is what already has been mentioned. And in this regards, basically this could be because of increased insulin, which could be transient, prolonged, or monogenic, which we discussed a lot. And then rarely there could be increased insulin action, which can be there. The approach already Dr. Vijay Kumar has mentioned that rule out the transient causes, manage with diazoxide. If not, go for diazoxide response. If there is a response, continue that, get a genetic study for GTH. If it's not there, get a genetic study for potassium ATP channel defect and decide whether a focal or a diffuse form could be there to decide the management. So main management is about diazoxide response and genetics. This is what has already been summarized. So we'll directly jump into the cases.
Uh, it was a 14-day-old boy presented with history of birth asphyxia, admitted in ICU with blood sugar levels of 28 milligram per deciliter. Was started on GIR of 14 milligram per kg per minute. It was non-ketotic with high insulin levels of 4.2 microunit per liter. The birth weight of child was 1.6 kg. Dr. Chetan, sir.
So this is a case of neonatal hypoglycemia, which is hypoketotic in nature, and any detectable insulin at the time of hypoglycemia is suggestive of hyperinsulinism. And we have two risk factors in this case. One is low birth weight, that is IUGR baby, and second is birth asphyxia. So these two can lead to transient or maybe temporary hyperinsulinism, leading to the prolonged use of diazoxide, and it can last up to 8 to 12 weeks as well. So after doing echo, we can start the diazoxide in these patients and see the response, how baby reacts.
On follow-up, child was started on diazoxide at 10 milligram per kg per minute. The GIR was reduced. There was now weight gain and edema, complaint of edema.
Yes. So edema is a known associated factor with the use of diazoxide. So along with the diazoxide, we should use hydrochlorothiazide because it is known to cause fluid retention. So along with the diazoxide, we should use low dose hydrochlorothiazide once a day.
This message was given very well by Dr. Vijay Kumar. So if it is 5 milligram, maybe avoid. 10, you should give a thiazide. Very, very important in that. So prolonged insulin, we discussed, is a good diagnosis. This is going to improve and we can get a good response in that perspective.
Coming on to the next case, 3-day-old boy presented with severe hypoglycemia with birth weight of 4.6 kg, was on high GIR of 18. Ketone was absent, and on testing the insulin level was 2.4 microunit per liter. Dr. Vijay, sir.
This is a clear-cut case. Actually, we have discussed this. This case, actually, we have started the diazoxide.
Yeah, so this is
we have
macrosomia.
macrosomia, everything, macrosomia, glucose, high glucose in insulin, and features of hyperinsulinism. So first that we can start is diazoxide, and we can send for genetic study.
Okay,
And
so yeah, we started diazoxide, increased to 15.
Start hydrochlorothiazide.
Hypoglycemia is persisting.
persisting.
So we
Then
should go for
octreotide, glucagon infusion.
And was found to have a
Potassium
potassium
ATP
ATP channel defect. So you just maybe reiterate the potassium ATP channel defect that you
Yeah.
just mentioned. I think.
Yeah. So actually there are two types. So whenever it is an autosomal biallelic recessive or monoallelic dominant, so there is a chance of diffuse thing. So we have to continue. We have to, we can avoid. So we have to continue with the other medical, intensive medical management. Suppose if it's a paternal KATP channel, so there may be a chance of focal disease, do a Doppler PET scan and go for surgery. That is the plan.
So clearly, again, the message is onset macrosomia refractory. Think of this is a very, very bad case too.
Coming on to the next case, 18-day-old boy presented again with hypoglycemia, birth weight of 3.4 kgs, on high GIR levels with ketone level of 1.2 and insulin of 2.4 microunit per liter. Dr. Ravindra sir.
Again, I think now the delegates have to answer. The question here, case is very clear, neonatal diabetes. What should we do? What should we do now next? We have to treat this case. Insulin is 2.4. I mean, hypoglycemia, if someone is having in such a high insulin, obviously it is hyperinsulinism, and any amount of detectable insulin is abnormal. So what should be done in this case? Very good. Start digoxide. So, because this is a case of neonatal hyperglycemia, because of the hyperinsulinism, we started the digoxide 10 milligram. No improve. My God. So this case is not improving. Still hypoglycemia is there. So what is the next step? It means it is having some sort of mutation which is non-responsive. As you see the algorithm, there is a one group of patient which is responsive, one group which is non-responsive. You again will go for the paternal mutation has been done. It is found to be the paternal potassium ATP defect. FDC PET must have been done, and it is found to be focal defect. If focal defect is there, then surgery is the answer, because otherwise the insulin will keep on secreting from that place no matter what sort of medication you are giving. Surgery has to be done. The problem is that you will find very few surgeons will be able to touch these neonates. I don't know about your city. I am from Delhi. I know. I mean, just couple of last year or 1.5 years back, there was someone has asked in our group, "Okay, is there any surgeon who can touch these baby?" So very few people they will be touching these baby, because doing pancreatic surgery is almost next to very difficult, because nobody will touch the patient. However, if it is early onset, normal birth weight, go for the genetic mutation, paternally inherited potassium ATP defect is there. FDC PET is the answer. You see, it is diffuse or local. If it is focal, go for surgery. And just one message which I think sir has just want to give. If it is neonatal diabetes, don't start oral hypoglycemic until unless you are having genetic mutation. If it is neonatal hypoglycemia, you can start the digoxide, because that is a treatment.
Sure. Wonderful. So next.
Next case, 21-day-old girl presented with hypoglycemia, birth weight of 3.2 kg, on high GIR requirement, ketone levels were 1.1 and insulin was detectable. Dr. Hari sir.
So I'll not elaborate more. This is clear-cut detectable insulin, high GIR, and day 15 neonatal hypoglycemia, and clear-cut hyperinsulinism. And the first-line therapy is always a diazoxide, which we start in such cases. So there was a clinical improvement after starting diazoxide, and the GIR was reduced gradually. But one thing which could see here is ammonia, which is quite high in this. But looking at the child, he was asymptomatic, I guess. I mean,
There
he
was
had
some
not
seizures later onset compared to the other children who had day 3, day 4. He had a
yeah.
later onset.
Because hyperammonemia usually suggests towards the urea cycle defect or some amino acid metabolism defect.
Yeah, from
but
that perspective, neurologically was not asymptomatic. Hypoglycemia was a
yeah,
symptom.
hypoglycemia was a symptom. So we have got something called hyperinsulinemic hyperammonemia syndrome, HEHA syndrome, which is because of a mutation in GDH. This is a constitutively active, active constitutively active, which converts alanine, I think aniline to, and reverses the ATP ADP ratio, and which causes membrane depolarization and hyperinsulinism. That is the mechanism in this, and they respond beautifully to diazoxide.
So as against, even if you don't do genetics and they're responding to diazoxide, it's good enough
Yes.
in this regard. So it's very nicely pointed by Dr. Ravindra that there is a difference between diabetes and that, because in neonatal hypoglycemia, you don't have any alternate treatment. In diabetes, you have insulin. So to stop insulin, you require a proof. But here to start, you don't need a proof because you have nothing else to do. You can give diazoxide. So again, very good scenario.
But how long this continues? I think for many years.
Yes, so often what happens, the requirements go down, but
Yes.
during intercurrent illnesses, they will again have a problem.
Because I have one
Mhm.
patient
Yeah.
of this. She is
So low
still
dose, they will continue on
on
that.
diazoxide low dose. She is still continuing.
Yeah, so that is a good diagnosis, and with age, they will come down. We have seen this.
Moving on to the next case, 12-day-old boy presented with lethargy with low glucose levels, with ketone level was negative, insulin levels were high during high critical sample, and birth weight of the child was 4.2 kg. There was umbilical hernia and ear crease present. Dr. Chetan, sir.
So this is a macrosomic baby having hypoglycemia due to hyperinsulinism with low ketone. So macrosomia might be due to infant of diabetic mother or due to other genetic issues. And in this case, umbilical hernia, ear crease, and a large baby is suggestive of Beckwith-Whitman syndrome, which represents with hypoglycemia due to hyperinsulinism, and genetic evaluation is necessary to stamp the diagnosis.
So it was proven to be 11p15 defect. And now Beckwith-Whitman syndrome, they may also respond to diazoxide, but sometimes they may not. Then you can think of focal lesion, which may be there, where surgery may be required in that.